If your LDL looks fine, but heart disease runs in your family, there's a lab marker that can change your plan overnight. It's called Lipoprotein A, or LPA, and it's the genetic risk layer most standard cholesterol panels never show you. LPA is largely inherited, mostly stable for life, and you can't keto it away, supplement it away, or positive vibe it into submission. But that's also the good news, because once you know it, you can stop guessing and start out planning it. Today we'll show you who should test, what high actually means, what helps, and what doesn't, and the action ladder that turns a scary-sounding genetic number into a calm, practical plan. Because high LPA is not a sentence. It's a signal. Let's start with what LPA actually is. Think of it like an LDL particle that showed up wearing an extra accessory. LPA is basically an LDL-like particle with ApoB on it, plus an additional protein called apolipoprotein are attached. That extra ApoA piece is why LPA isn't just a cholesterol story, it's also a more inflammatory, more clot-friendly particle story. So one simple longevity compass translation is this. LDL is a particle problem. LPA is a particle problem with extra attitude. Now why is LPA such a big deal? Because it can explain a very common mystery. My labs look okay, so why did my dad have a heart attack at 52? LPA is an independent risk factor for heart attack and stroke, even when LDL-C is decent. Lowering LDL helps, but it doesn't automatically erase LPA-related risk, which is why you want LPA and ApoB in the same conversation. Now the genetics myth bust. LPA levels are predominantly genetic and usually stable across adulthood, which is why many groups recommend measuring it at least once in adulthood. If it's low, you generally don't need to keep retesting it every year like it's a stock price. If it's high, you don't need to recheck it monthly like a blood glucose meter, you need a better prevention plan. Here's a critical practical trap. LPA can be reported in milligram per deciliter or nmol, L, and those units are not safely interchangeable with one universal conversion factor. Why? Because the ApoA protein varies in size from person to person. So if you see a flashy conversion chart online, treat it like a TikTok tax advisor, entertaining, not authoritative. Now, who should test? The simplest modern answer is basically all adults should get it checked at least once. But your high suspicion list is premature heart disease in the family, strokes that feel too early, suspected familial hypercholesterolemia, or coronary calcium that doesn't match your lifestyle. And yes, LDL looks okay but family history is scary, is basically the LPA origin story. Now let's define what high means without turning it into a yes or no label. Risk rises on a continuum, but clinicians use thresholds to decide how aggressive to be. A common framework is lower risk below about 30 mg per deciliter, a gray zone from 30 to 50 mg per deciliter, and higher risk at 50 mg per deciliter or above. In nmol/L terms, that higher risk threshold is often around 125 nmol/L or above. Here's the mindset shift that makes this empowering. You can't reliably lower the LPA number with lifestyle, but you can absolutely lower your event risk with lifestyle and the right medical strategy. You can't out-diet the lab, but you can out-plan the phenotype. So let's build the action ladder. Step 1. Crush the modifiable particle burden. If LPA is your genetic risk tax, ApoB is the part of the bill you can usually negotiate. That means ApoB, non-HDL cholesterol, and LDL-C targets become more important, not less. In real life, the goal is often drive ApoB down farther, because you're carrying an inherited risk layer. Food doesn't erase LPA, but food can move ApoB. The highest yield levers are boring. Less saturated fat, more unsaturated fat, more soluble fiber, fewer ultra-processed calories, and a protein plan that doesn't rely on daily processed meat. Then comes the medication conversation, and here's the boundary. You don't self-prescribe anything from YouTube, but you should understand the logic so you can talk to your clinician like a grown-up. Statins don't lower LPA, and may nudge it up slightly, but they reduce cardiovascular events and are often foundational when risk is high. Ezetimibe doesn't meaningfully lower LPA either, but can help lower LDL-C and ApoB. PCSK9 inhibitors are the most relevant current meds in the LPA conversation because they can lower LDL-C and also reduce LPA modestly, often around 20 to 30% in studies. They're not approved for LPA, but they can be useful when high LPA comes with a need for more aggressive ApoB lowering. Now, quick myth bust. The supplement aisle is not your LPA solution. Lifestyle changes usually have minimal impact on the LPA number itself, and most supplements don't meaningfully lower it in a way that's proven to reduce events. Niacin can lower LPA in some studies, but it's not routinely recommended for cardiovascular risk reduction because outcomes and tolerability haven't made it a clean win. So the play is not chase the LPA number at all costs. The play is lower the risk around the number. Step 2. Remove the accelerators. Genetic risk is like a fire, and the accelerators are the things that make it spread faster. The big accelerators are blood pressure, visceral fat, diabetes risk, smoking, and poor sleep. If you have high LPA, you don't get to have optional blood pressure because high BP stacks risk with everything else. Sleep apnea is a huge hidden lever. If you snore loudly, stop breathing at night, or wake up unrefreshed, your heart risk story may partly be an airway story. Alcohol can be another sneaky accelerator, especially if it pushes your BP up, wrecks sleep, or triggers palpitations. With genetic risk on board, you want fewer, avoidable hits. Step 3. Consider imaging when it changes decisions. Coronary artery calcium, or CAC scoring, doesn't measure your blood, it measures calcified plaque burden. If CAC is elevated and LPA is elevated, risk can stack and the prevention plan often gets more aggressive. But don't let a CAC score of 0 lull you into complacency, especially if you're younger, because 0 calcium can underestimate lifetime risk. The best use of CAC is a simple question: would the result change what you do next? If yes, discuss it with a clinician. If no, your best move is usually fixing the modifiable levers anyway. Step 4. Remember, LPA is also a valve story. Elevated LPA has been linked to calcific aortic valve stenosis, not just clogged arteries. That doesn't mean everyone needs an echocardiogram tomorrow. It means if you have high LPA and develop exertional shortness of breath, chest pressure, fainting, or you're told you have a new murmur, you take it seriously and get evaluated. Step 5. Family cascade testing. This is the most underrated benefit of the whole test. If your LPA is high, first-degree relatives have a higher chance of also being elevated. One person tests, a family gets information, and that can prevent, surprise, heart disease from becoming a family tradition. Now the future, without hype. There are LPA-targeted therapies in late-stage trials designed to lower LPA dramatically. Some have shown very large reductions in the number in earlier studies. But the only question that matters is whether they reduce heart attacks and strokes, and we're still waiting on definitive outcomes and approvals. So here's your longevity compass bottom line. LPA is the lab that can explain why good cholesterol didn't protect your family. It's not a reason to panic. It's a reason to tighten the plan. Lower ApoB harder if warranted, nail blood pressure and sleep, consider imaging when it changes decisions, and test the family. That's how you outplan genetics. Quick safety note: this is educational, not medical advice. If you have symptoms like chest pain, fainting, stroke symptoms, or new severe shortness of breath, seek urgent medical care, not a new supplement stack. If this episode helped, hit like and subscribe. Check the description for tools and affiliate links that match today's episode, plus our Longevity Compass Amazon KDP book. And drop a comment: have you ever had a "my labs are fine, but my family history is scary" moment? Because that's exactly the kind of story where LPA turns confusion into a plan.